So I want to go into that, which will hopefully take about 20 or 30 minutes. And then we'll go into the blood vessels material. So the next issue to consider with the heart is really about what we call cardiac output. And this is a way to determine or describe cardiac function, how well the heart's doing its job. And the mathematical definition of it is at the bottom of this image. Cardiac output is the product of heart rate and stroke volume. Now, we'll talk a little bit more about heart rate, but you really are kind of already familiar with most of that. What heart rate is, because we talked about it in terms of the autonomic system. But stroke volume is something that's probably new to you. So let me introduce and define that. And let me just open up a notepad here. So stroke volume equals EDV minus ESV. So that's basically what the figure down here says. Stroke volume, SV, equals EDV minus ESV. And so that, of course, begs the question of what EDV and ESV stand for. EDV is the end diastolic volume. And, sorry?
We did this.
We did this.
Yeah.
Okay, Crystal, you lied. That's not what we didn't stop with love duck.
Sorry, I don't remember this part.
Okay.
That was the last thing I had on my paper.
Sorry?
So we're past
Okay, what did we end with?
with cardiac output equals HR times SV. Like the picture that you had.
So we were there. Okay, let me just, for the sake of completing this.
It's good review.
Sure. So in the interest of review, what does it mean to talk about the end diastolic volume? What does that actually mean?
Release.
It's the volume in the ventricle when?
At the end of the diastole.
Yeah, so at the end of ventricular diastole, whatever volume is there, which basically means as full as the ventricle is going to get. That's the maximum volume, because that's at the end of ventricular filling, both the passive component and the active component at atrial systole. Okay. And what does end systolic volume mean? Right. So ventricular systole really means when the ventricle is ejecting the blood into the arteries. And so at the end of that, that's going to be end systolic volume. That's the end of, that's the lowest point. That's the smallest volume. That will not be zero. The heart does not eject all of the blood in the ventricles. With each contraction, there's going to be some left over. If it were to completely empty out, then the ventricle would have to be completely collapsed and no space left over. And it isn't ever going to do quite that. So that's what stroke volume is. It's the difference between the highest volume and the lowest volume in the ventricle. And so cardiac output is combining those two things. And if we think about the units involved, stroke volume is traditionally measured in milliliters. Actually, let me. Oh, that's right. I want to put there. Okay. cardiac output equals heart rate times stroke volume. And stroke volume is traditionally in milliliters, and that's how many milliliters are ejected per heartbeat. Is this new?
Mhm.
Oh, good.
Sorry, I left early and totally forgot about that.
Okay, that's
My
fine. And so heart rate is the number of beats per minute. Okay. And let me make this smaller. So if we multiply those two together, then cardiac output will have to be beats per minute times milliliters per beat. And if we multiply those two ratios together, the beats on the in the heart rate will cancel out with the beats, which is always 1, in the stroke volume, which means that cardiac output is going to necessarily be the milliliters per minute. If we consider some traditional numbers, the resting heart rate is usually around 75 beats per minute, and stroke volume, a normal value for that would be 70 milliliters per beat. Okay. And so what's that product going to be? What's 70 times 75? Crystal, did you just do it in your calculator?
5,250.
5,250 milliliters per minute. Okay. And we could simplify that a little bit by just saying about 5 liters per minute. Okay. That's what we would call resting cardiac output. Okay. When the heart's at its resting heart rate and the heart isn't working any harder than it normally would, we should be pumping about 5 liters of blood through our heart per minute. That happens to be pretty much the average amount of blood in somebody's body. There's nothing terribly cosmic about that. It just sort of works out that way, as far as we're concerned. But that's what it wants to do. Now, cardiac output is telling us how much work the heart can do. And so resting cardiac output is what's happening at any given time. But we will want the heart to do more work occasionally. And so anything we can do to increase cardiac output is going to push us towards our maximal cardiac output. And that means that we can do things to change heart rate and do things to change stroke volume. Now, maximal cardiac output for your average person is about 3 or 4 times an increase. So your average person can probably go from about 5 liters per minute to 15 or 20 liters per minute. People who are in very good cardiovascular health, people who are athletes that are always training, their maximal cardiac output is actually going to be much higher. They can go to 35 to 45 liters per minute. So they can increase it 7 or 8 times its normal value. And there's a couple of ways that happens. Now, in this picture, they address a few things that affect heart rate and a few things that address stroke volume. And I want to talk about some of these individually. As far as the heart rate's concerned, the most important aspect of that is autonomic innervation, which we've already talked about. Largely, we adjust our heart rate by having the sympathetic or parasympathetic systems adjust that effect. hormones really aren't primarily concerned with adjusting heart rate. There are hormones that do have an effect on it, but it's usually because that's secondary to whatever the hormone happens to do normally. And then, like I mentioned a second ago, being cardiovascularly fit will have an effect. And then age also can have an effect. But I want to talk more about the autonomic innervation. Now, this picture simplifies things a bit, but what we see here are central neurons that are projecting out and synapsing in the periphery, and then, oh, actually, I shouldn't say it that way. Oh, that's weird in the picture, but then we have outputs going to the heart. The reason I stopped there is I just realized this reddish colored projection here also has another peripheral synapse. So this picture is not the greatest with what's going on anatomically. And I'll talk about the anatomy in a second. But in the medulla, there's a region called the Cardiovascular Center. It's what's largely responsible for coordinating what's happening with the whole cardiovascular system. This, of course, is adjusting what's going on with the heart. The cardiovascular system also has a role to play with blood vessels and blood pressure, which is part of the topic in the next chapter. Within the cardiovascular center, there's basically two regions. There's a cardio-acceleratory area and a cardio-inhibitory area. So the acceleratory area is named because it tends to increase heart rate, and the inhibitory area decreases heart rate, which basically corresponds directly to sympathetic and parasympathetic inputs. The cardio-acceleratory area, there's going to be a central projection that synapses in the sympathetic chain ganglia, and then that's going to go out and connect directly to the heart. And that's what this purple line represents, labeled sympathetic cardiac nerves. These will also be called the cardio-acceleratory nerves because they're primarily concerned with raising heart rate, speeding up the heart rate. There's a bit more that they do than just that. And we'll get to that bit more with when we talk about stroke volume. But the ending coming here really should be placed a little bit off to the side, is going to the SA node. And then an ending here, again, should be just placed a little bit further over. And that's going to the AV node. And so with those two connections, the sympathetic system can speed up heart rate. The other connections are going to the ventricular wall, and we'll talk about what they do in a little while. But as far as the cardio-acceleratory effect on heart rate, it's really going to the SA and AV nodes. Now, I do want to explain why this picture isn't anatomically correct, and there's several reasons or several problems with it. It's not meant to necessarily be anatomically perfect, but one thing that I want to be sure you understand is the output from the medulla doesn't go straight out to the chain ganglia. Really what's happening is the medulla projects down to the thoracic spinal cord, and then the thoracic spinal cord sends out preganglionic sympathetic fibers, which then synapse in the ganglia, and then the postganglionic sympathetic fibers are these cardio-acceleratory nerves, or the cardiac nerves that we see here. And the postganglionic fibers are the ones that end on the actual heart. Okay. So as far as this is concerned, the way it's drawn, it's a little incorrect. It suggests that there's a projection directly out of the medulla. It's not. It goes down to the thoracic spinal cord and then out. And basically any textbook that's presenting this information is usually going to overlook that anatomical point because they're really just getting at the brainstem influences this stuff. On the other side, the inhibitory area, it's going to send a signal along the vagus nerve, which then synapses on the terminal ganglia at the heart, which is not necessarily floating off to the side here. It might actually be the point here for the parasympathetic system. It's going to be synapsing very close to it here. And then from that terminal ganglion, the postganglionic fibers go again to the SA node and the AV node. Now, again, this is not necessarily anatomically correct the way it's drawn, but the fact that there's a purple and a red, I don't think that's really red, but whatever, ending side by side here and purple red ending side by side here, that's supposed to represent the projections to the two nodes. The sympathetic and parasympathetic systems both project to both of those nodes to influence their activity. The sympathetic system has other projections into the wall of the heart, which we'll talk about later, but the parasympathetic system doesn't. Actually, there might be a very small projection to other parts of the heart from the parasympathetic system, but effectively there isn't, and we can basically ignore it. Which is to say that the parasympathetic side really only affects cardiac output through heart rate. Okay? The sympathetic system is going to have other roles to play, but parasympathetic really is only going to influence the SA node and the AV node and have an effect on that. Actually, let me back up for a second to this picture here. When we're talking about stroke volume, we're talking about adjusting the volumes of blood that we see at any point in this system. So a simple difference in volume is just going to come from heart size. There's going to be some variation in heart size from person to person, but that doesn't really matter. That's not what we're concerned with. More anything that affects the heart size, usually pathologically, is going to have an effect on stroke volume. It might seem like that could be advantageous, that a bigger heart's going to have larger volumes and therefore stroke volume should be larger. But in fact, most conditions where heart size is affected, it's also going to affect the ability of the heart to pump effectively. So in the end, it's actually going to decrease stroke volume. Fitness levels are going to have an effect here also. And then gender does. And that kind of goes to the effect that gender has on skeletal muscle, that thanks to testosterone, men are going to have more skeletal muscle. They're also going to have more, or at least more efficient cardiac muscle too. Okay. The things that we want to consider are actually down here: contractility, preload, and afterload. And the figure that I started to go to that I backed out right here is addressing that. So the major ways that we affect stroke volume, other than the ones that I mentioned earlier that we don't necessarily have a lot of direct control over, are preload, contractility, and afterload. Preload is actually a characteristic of any muscle tissue. Here we're considering it in terms of the cardiac muscle tissue, but really the same thing applies to skeletal muscle tissue. And it's a little easier to demonstrate in terms of skeletal muscle. What preload really means is we can stretch the muscle out a little bit and get more contraction out of it. Recall from ANP1 that sarcomeres are overlapping thin and thick filaments which slide across each other. If you can stretch out the sarcomere so that the thin and thick filaments are pulled further apart, then there's going to be more distance for those thin and thick filaments to slide across each other during contraction. And that's what preload is really getting at. So imagine skeletal muscle. Imagine I'm going to throw a ball, and I actually have a doorstop in my hand, but that's what I have available. If I wanted to throw it, I could just do that, not get a whole lot of distance out of it, because I'm not really doing much with the biceps brachii to get it to contract as well as it can. But if I stretch the biceps brachii out before throwing like this, then I can get a lot more power out of that throw. And that's basically addressing the idea of like winding up before throwing a baseball or something like that. Stretching the muscle out a little bit gives the sarcomeres the ability to contract a bit more when they're being asked to contract. That's what preload is. In terms of the heart, preload is really about stretching the muscle out a little bit before contraction. And we're really talking about stretching the wall out the same way that a water balloon stretches out. You put more water into a water balloon, then the rubber of the balloon is going to stretch out. For preload in the heart, you basically put more blood into the ventricle, and it'll stretch out more and give you that extra contractility, or I shouldn't say contractility, extra contraction. That can happen either by allowing the filling time to, I shouldn't say, to allow the filling to take place quicker. There could be more pressure behind the blood, pushing it into the ventricle faster, or something like that. Or you can have an extended filling time. If the heart beats slower, then there's going to be more time within a single heartbeat for blood to get into the ventricle. So anything that increases the filling there is going to help. And then the other thing that's listed here is the increased venous return. Venous refers to the veins, and so increased venous return is to say that more blood's returning through the veins to the heart. In the veins, there's actually extra blood kind of hanging out. It's not that it's stuck in some corner not moving around, but as far as the volume of blood in your system, the majority of it's actually in your veins. Veins are large vessels. There's a lot of space in them. So there's a lot of blood volume in them also. And if we need to get a quick change in preload, we can just contract those blood vessels so that they're thinner and they have less space for blood. And then more blood will return back to the heart with each heartbeat. And that blood coming back is going to increase what fills the ventricle and will stretch out the ventricle. This increases the end diastolic volume. Okay? We get more blood into the heart at the end of diastole, and then when the heart does contract, stroke volume will be higher, just because the difference between EDV and ESV is going to be greater. Okay. There aren't a lot of reasons why we would want to purposely lower preload and therefore cardiac output, but there are a number of things that can have an effect on it. A lot of these are going to be side effects of drugs or conditions that people might have that'll affect it. So it's really not how we regulate cardiac output, but rather the things that can have an effect on it. Contractility is something different. As I was describing preload, if we stretch the sarcomere out, we get more contraction. That's not actually what contractility is getting at. Contractility is about getting more contraction out of each action potential in the muscle fiber. And that really gets to the a change in calcium levels. Calcium gets into the sarcoplasm. It binds to troponin, trypomyosin moves out of the way, and myosin and actin can interact, and you have sliding filaments. The more calcium that's present, or the longer that the calcium is present, then the more contraction you're going to get. We call that contractility. It's a more efficient contraction. So I'm pointing out here high blood calcium levels because that's the most direct aspect to it. That plateau in the action potential is because of calcium. So if the calcium levels are high, then more is going to enter in through that plateau, and you're going to get increased contractility. That can be affected by increasing the amount of calcium in the cell, which has to happen earlier, so more calcium can be stored in the cell, so it's able to be contractile. And then it says sympathetic stimulation and epinephrine and norepinephrine, which really are the same thing. Now, norepinephrine is the neurotransmitter released from sympathetic postganglionic fibers, but then epinephrine is being released from the adrenal medulla because of sympathetic activity. So all of that kind of goes together, and that gets at the other connections that we see here. So along with the cardioacceleratory nerves that end on the SA and AV nodes, there are branches that also go across the ventricular wall, mostly the left ventricular wall, although not all of them. And in this picture, it's rather schematic, so they're not showing all of the different branches. But this ending here suggests that there's some going to the right side, but there's more going to the left side. And the adrenergic receptors there are directly tied to calcium ion channels, because that's going to increase the amount of calcium that goes into the muscle fibers in that area, and that's going to increase contractility. Contractility affects end systolic volume, so that means that during systole, the muscle is going to contract more efficiently, more extensively, and more blood's going to be ejected. So by lowering ESV, we also get a greater difference between the two volumes, and that's going to increase stroke volume. We saw with the connection to the sympathetic system that those two are under control of those. There are some hormones that play a role in contractility also. But primarily when we're affecting stroke volume, controlling cardiac output, it's preload contractility that we have control over. The third thing here, afterload, isn't really something that we control so much. It's essentially just the blood pressure in the system. The ventricle has to contract and generate enough pressure to push through the semilunar valve. And if the pressure on the backside of that valve is too high, then the ventricle has to contract more and more to overcome and open up that valve. If your systemic blood pressure is high, it's supposed to be 120/80 or lower. If it's, say, 140/90 or whatever, then the pressure that the ventricle has to overcome to start ejecting blood is higher, and it's not going to be able to get as much blood out. Okay. We do have ways of directly affecting systemic blood pressure in an acute sense, which means if we see a change in blood pressure, we have a way to affect that. We'll talk about that in a lot of detail with the urinary system because it's really under the control of the kidneys. But that's only acute. Chronic high blood pressure we really can't affect. If your system is chronically high, then the homeostatic mechanisms that regulate it are going to become accustomed to that. So afterload, to some degree, just is an example of how high blood pressure will directly influence cardiac output in the long term. When blood pressure is high, which is what vascular resistance means, then end systolic volume will increase, which sounds a little strange, so let me just explain that. if end systolic volume is supposed to be at a certain level, increasing it means that we've ejected less blood. Okay, so increase sounds like a positive movement, but really we're trying to get that value as low as possible. So afterload is going to keep end systolic volume high, which is going to mean that stroke volume decreases. With stroke volume, I'm mostly talking about the sympathetic system's ability to change things. I pointed out that the various things lower preload in the first column here. There are some other things that affect contractility and afterload there, but again, that's not really stuff that we have an ability to regulate so much. It's mostly about getting preload and contractility up, which is going to increase stroke volume. Everything else here decreases stroke volume except when our blood pressure is low. And other than acute changes in blood pressure, we really can't do anything to affect afterload directly. If you have high blood pressure, then you'll probably be recommended to do things to get it down, but that's more about better diet, cutting salt out and that sort of thing, which isn't going to affect stroke volume directly. Eventually, you'll have better cardiac output because of it, but it's not something that we can homeostatically regulate the way that we can preload and contractility from the sympathetic system. In the book, right after the figure I was just showing you there, they have this figure which kind of puts a lot of this together. The bottom half of this picture, which is the major things going into heart rate and into stroke volume, is essentially what the first picture I showed you where I was defining cardiac output comes from. And this just goes back and points out preload, contractility, afterload, which are the major things that we talked about having an effect, and a few of the different reasons why that can change. There's a little bit of interaction between heart rate and stroke volume, part of which has to do with the atrial reflex, which means that when the atria are stretched out, they're going to reflexively try to lower things so that they don't get overstretched. And some of that has to do with regulating blood pressure, again, which will come up when we talk about the urinary system. But there's a hint of there's some interaction with that here. But generally, anything we can do to change heart rate or stroke volume individually is going to change cardiac output. Earlier, I mentioned that fitness levels have an effect on this. The book mentioned that too. Somebody who's cardiovascularly fit is usually going to have a very low heart rate. We usually think of heart rate, resting heart rate, as being around 70 or 75. In the case of somebody who's cardiovascularly fit, it's likely to be more like 40 or so. 60 or so. That gives somebody that's fit like that the ability to increase cardiac output more than somebody with a normal fitness levels. If we start from 75, there's just so high we can change heart rate. But if we start at 60, we can get more change out of the heart rate. Now, somebody who's cardiovascularly fit, if they have a low heart rate, that doesn't mean that they have a low resting cardiac output. Actually, along with the lowering of the heart rate is going to be some increases to stroke volume. Mostly their preload and contractility are going to be at rest higher than your average person, which will balance things out. And so resting cardiac output for everybody's going to be in the same kind of range. It's just that somebody that's cardiovascularly fit can certainly make that change much greater and get a lot more output from their heart when they need it, when they're exercising, something like that. It also mentioned that age has an effect on some of these things. If you exercise, you might be familiar with considering your maximal heart rate. If you get on a cardio machine like a stair climber or something like that. The rule of thumb for heart rate is 220 beats per minute minus your age, which is not an exact estimate, but it gives you a pretty good idea, which is to say that a 20-year-old might have a maximal heart rate of about 200 beats per minute, a 40-year-old about 180 beats per minute, a 60-year-old 160 beats per minute. Just generally, that's kind of how the heart rate tends to decrease with age. Somebody's resting heart rate is going to generally be in that normal 70, 75 range. That's not what goes down. It's the ability of the heart to increase heart rate to a maximal level that decreases with age. Okay. That should be, yeah. So that finishes off talking about cardiac function, considering the cardiac output and the factors that influence it. Any questions about that material? The real sort of take-home message for this is to apply what you've learned about the autonomic system and endocrine system to this. I stress more of the sympathetic inputs, ability to change cardiac output. Pay attention to all of that, those factors that will affect cardiac output. Okay. And autonomic innervation and hormones are mentioned both for heart rate and for stroke volume, mostly on contractility, but they have an effect on both of those. So any questions about wrapping up the heart stuff here? Okay, so we'll move into talking about the vasculature, blood vessels. And the blood vessels chapter starts off with this picture. That's just another way of looking at pulmonary versus systemic circulation. And we're mostly concerned with the systemic circulation side of things. And there's three major types of vessels we're going to consider. Coming away from the heart, going out to the body, we have arteries, which then feed into capillaries where various substances are exchanged between the blood and the tissues of our body. And then the blood moves out of the capillaries into the veins, which then carry the blood back to the heart. That's a very simplistic idea, those three major types. We're going to look at types within that. There's really kind of 6 types of vessels that blood flows through from when it leaves the heart to when it comes back to the heart. So we're going to talk about some of those. To begin with, we want to talk about the structure of blood vessels. The picture at the bottom here, the micrograph at the bottom, I spoke about in lab yesterday with the Monday group, and I'll speak about in lab tomorrow with the Wednesday group. So we'll get to that. But I didn't talk about what's at the top here with the Monday group, and I won't tomorrow because we want to talk about it here. These two pictures are just getting at the structure that we see in the wall of a blood vessel. Now, zooming in on it, it cuts off some of what's in the vein, but really the list here kind of corresponds. There are 3 brackets up here showing the 3 different layers or tunics of a blood vessel. We can see the brackets on the other side, but the labels are cut off. The labels are exactly the same. The innermost layer of a vein or a artery is called the tunica intima. The term intima has always kind of bothered me. I prefer it be called the tunica interna, but I'm not in charge of naming things. It just makes more sense. Interna, externa are obviously opposites. But intima really comes from the word intimate, in that this layer is intimately involved with the blood. It's what's adjacent to the blood immediately. For both arteries and veins, it's the simple squamous epithelial lining to the blood vessel and the associated connective tissue. That simple squamous epithelium is referred to as the endothelium, which is labeled right here, and the same label's cut off on the other side for the vein, but they're both referred to as endothelium. They have an areolar connective tissue adjacent to them, as any epithelium would. That endothelium and its areolar connective tissue is basically continuous with the endocardium. It's pretty much the same thing throughout the whole cardiovascular circulation. It's one continuous lining to the entire system. In the vein side, you do not see what's in the artery side, which is this bluish looking line that's going back and forth. This is what's called the internal elastic membrane, or other sources will call it the internal elastic lamina. It's a layer of elastic fibers. Elastic fibers integrated into areolar connective tissue or elastic tissue are kind of the same thing. But there's this internal elastic membrane. The endothelium of the artery has a little bit of some texture to it. It's kind of folded up or scrunched up a little bit. Compare that to what we see in the vein. That's because of the elastic tissue. If the elastic tissue weren't there, if it weren't kind of pulling in a little bit on the wall of the artery would be relaxed and the inner surface would be nice and smooth, like we see with the vein. But that's the elastic tissue is important in the artery here. The next layer, the tunica media, is the muscle tissue layer. It's smooth muscle. There's some in arteries and in veins. Arteries tend to have more muscle than veins, but there's going to be some in veins also. A difference, however, between the two is, again, about elastic tissue. So there's an external elastic membrane. This label's pointing to the very edge of the outer edge of the tunica media, but there's really some elastic tissue within the media also. It's part of the tunica media. It's in arteries. It's not in veins. And just like the internal elastic membrane, it sort of pulls in and keeps the artery a little bit on the contracted side, just naturally. And then the outer layer is called the tunica externa, which is just loose connective tissue surrounding the outside of the vessel and anchoring it in place to whatever tissue it's going through. In the larger blood vessels, there are little blood vessels in the wall of the larger blood vessel. So this round thing here and this one here that's labeled are called the vasa vasorum, which basically means blood vessel of the blood vessel. The blood going through the blood vessel here is going to supply the tissue with oxygen and nutrients and carry waste products away, except when we're talking about a very big blood vessel, the wall's too thick for efficient exchange between the blood in the center and all of the tissues of the wall. So there are more blood vessels in the outside layer of large blood vessels helping nourish the outer tissues there. In smaller vessels, you're not going to see that sort of thing. And we have some in the vein also. Also in the tunica externa, these yellow dots here are the nervi vasorum, or the nerves that are in the blood vessel wall. That's not exclusively for large blood vessels like the vasa vasorum, but there's going to be nerve endings that are connecting to this material, and that's going to cause a smooth muscle to contract. So if we're talking about nerve fibers that are causing smooth muscle to contract, what aspect of the nervous system is that nervous tissue from? What division?
Autonomic.
Right. Because autonomic controls smooth muscle, cardiac muscle, glands, and somatic controls skeletal muscle. So these are going to be autonomic fibers. Within the autonomic system, primarily which of the two divisions is responsible for controlling blood vessels and blood pressure? Yeah, it's mostly sympathetic. Now, there are exceptions to that. There are some parasympathetic fibers that we'd find here, but generally speaking, most of these nerves are going to be sympathetic postganglionic fibers, and they're going to cause contraction of that smooth muscle. But there are some situations where parasympathetic has control of certain blood vessels, especially ones that need to dilate a lot. So those are the components of the wall of a blood vessel. Okay, the labels here we're seeing all for the artery, but really the labels that are cut off on the other side here are the same thing. So there's an endothelium for the vein. There's smooth muscle in the tunica media. There's also some smooth muscle sometimes out in the tunica externa, especially in the larger veins. Just that it, dealing with the venous return, I said earlier that the majority of the blood, not the majority of blood, but a large component of your blood is found in the veins largely. And so there's some additional smooth muscle there that helps us directly influence venous return. The vasa vasorum that we pointed out earlier is there. They don't label it, but there's a nerve ending in the tunica externa here also. So the two are kind of set up the same way. It's not in this picture because it's sometimes not an obvious thing to put in here, but we're going to talk about the third type of vessel, the capillary. It's different from arteries and veins because it does not have three layers to it. Okay? And that's why it's not really here, because it's like, here are two things that are the same and the third thing that's not. They just leave that third thing out. But a capillary is basically just the endothelium and its associated connective tissue. Capillaries do not have any muscle tissue, and therefore they don't have any outer covering either, tunica externa. We wouldn't really say that the capillary is just the tunica intima. That's not exactly appropriate, because that suggests that there should be other layers, but there's no other layers. It's really just the endothelium and its associated connective tissue. Again, in lab tomorrow, as in lab yesterday, I'm going to talk about the micrograph in this picture, which is going to relate back to some of the things I said there about the structure of the blood vessels. There are actually three types of vessels that fall into the broader group that I was just calling arteries. There are two different types of arteries that are called arteries. There's the elastic artery and the muscular artery. The difference there being mostly in the relative amount of elastic tissue versus the relative amount of muscle tissue. It might look like the elastic artery has a really big component of muscle tissue there compared to the muscular artery, but really that's a matter of size. These three pictures are not drawn in the same scale, so we really can't compare them that way. But there's a lot more elastic tissue in the elastic artery, which is why it gets that name. Also, functionally, elastic and muscular describes a little bit what those arteries are about. Elastic arteries really, it's more important that they can stretch out and then recoil back to their original shape. The primary elastic artery is the aorta. And every time your heart beats, there's 70 or so milliliters of blood that's ejected directly into the aorta. So the elastic tissue gives it the ability to stretch out as that volume is ejected into the aorta. And then it snaps back to its original size. In doing that, I shouldn't say snaps back. It's not like a rubber band that suddenly goes back, but the elastic tissue pulls back to its original size. And in doing that, it actually helps to push the blood out of the aorta on into the rest of the circulation. The blood can't go back into the heart because the semilunar valve's closed. So the only direction blood can go is into the systemic circulation. And that's driven largely because of the elastic fiber in the aorta wall. Muscular arteries, it's hard to really see that they're more muscular than elastic arteries, and that might actually not be the best way to describe it. There's less elastic tissue in them, so they're not as elastic arteries. But functionally, the muscular part is really important. Muscular arteries are largely responsible for distribution of blood. When the muscle layer contracts and makes the blood vessel narrower, blood's not going to flow through that vessel, and it'll rather go through a wider diameter vessel. And so muscular arteries, by contracting in certain places and staying relaxed in other places, help to direct the blood flow to different parts of the body. And then the third thing here, which isn't really an artery, we don't call it something artery, is called an arteriole. And this is really just a microscopic artery. It has the same 3 layers, but now we're looking at much larger cells, again, not drawn on the same scale as these other things. So these are very, very small blood vessels. They have elastic tissue, an inner elastic membrane and an outer elastic membrane. They have smooth muscle walls in the tunica media, and they have the inner and outer layers that we've seen before. Now, I just want to make a point about this word arteriole, because there's 2 words that you'll hear me say. There's arteriole and arterial. Okay. In pronouncing them, I really try to stress the O sound in arteriole. And if you don't hear that O sound, then you can assume I'm saying arteriole. An arteriole is a microscopic artery. And the word arteriole really means little artery. Arterial is the adjective of artery. And we usually hear arterial in the sense that we're talking about the arterial blood flow. Earlier when we talked about cardiac output, I mentioned venous return. Venous is the adjective form of vein, but there's not a word that we would confuse that with. But if we're talking about venous circulation, that's the blood going through the veins. Arterial circulation is the blood going through arteries. And then again, when I say arteriole, I'll stress the O sound. So if you don't hear that O sound, I'm probably saying arterial as an adjective form of the word artery. Okay. And in some places, the meaning isn't terribly important. I'll talk about the arterial flow into capillaries, which is getting to our capillaries through arterioles. So the 2 kind of overlap. But it is important to kind of think about the part of speech that we're talking about here. Okay, now where were we there? I looked at that one. Okay, so those are arterioles. Now, capillaries we can distinguish into 3 different types, but this is different from the picture I just showed you with the 3 types of arteries. Oh, let me go back to this picture actually. Whoops, here, there we go. As we're considering systemic circulation, the blood has to move through elastic arteries like the aorta, and then through muscular arteries which decide where the blood's going to flow, and then arterioles which go into the capillaries. So blood is going to travel through all 3 types of artery type vessels that I just pointed out here in the systemic circulation. It doesn't go through this type but not this type in some places and vice versa. All 3 types are part of the systemic circulation. But when we get into the capillary beds, depending on which artery, which organ we're talking about, we might see different types of arteries. Said that wrong. Might see different types of capillaries. So while this picture is showing us 3 different types of blood vessels, that's going to be in any pathway for cardiovascular circulation, this picture is showing us 3 alternate possible types of capillaries that we might see in any particular place. And they're categorized basically on how leaky they are, or how little blood they allow to slip through. So the least leaky type are the continuous capillaries. And what characterizes them is that they're very tight junctions between the cells making up the endothelium. So barely anything can get through those gaps there, called the intercellular class. Really the only things that can are small molecules like water or electrolytes, ions, and that sort of thing can move through there. But bigger molecules like glucose or amino acids or something like that can't move through the intercellular class. The only way those larger molecules can get out of the blood and into the surrounding tissue, or molecules from the surrounding tissue can get into the blood, is through active transport across the endothelial wall. So it's not demonstrated in this picture, but if there's a glucose molecule in the blood here, it'll move through a vesicle, move through the cell within a vesicle, and then leave the cell. All of that requires a lot of energy to transpire. We see continuous capillaries in tissues where we want to have very strict control over what gets from the blood and into the tissue. What's a good example of an organ that has that kind of privileged blood supply? No. No. Where do we restrict blood access to tissue? Brain, right. The blood-brain barrier has continuous capillaries. The blood-brain barrier is a little bit more restrictive than even what I suggested there. And that's because astrocytes also play a part there. So astrocytes in the central nervous system surround continuous capillaries, so we have a very strict regulation of what can move out of the blood and into the central nervous system tissue. But elsewhere, we have continuous capillaries where we still have some regulation over what can move in and out of the blood. The next type is the fenestrated capillary. The word fenestration means window. Okay, from the Latin, it means window. In school, I studied German and Spanish. And the German word for window is Fenster, and the Spanish word for window is ventana. But I just told you that fenestration is a Latin word, and you would not expect a Latin word to make its way into German, but in fact that's the case. And then the Latin word is not the root of the word for window in Spanish, which is really unusual. I was talking about this in one of my other classes last week, and one of the students there pointed out that in French, sorry, that in French, the word for window is fenester or something like that. There we go. So I don't speak French, so I didn't know that. I hadn't heard about that. But that's a better example of the Latin word for window getting into a Romance language. In English, we don't really use that word, obviously, because we call it a window. The only time that I've ever seen any reference to this word referring to windows is in the term defenestration. Has anybody ever heard of defenestration? It's a very fancy way of saying something's going out a window. So if you're upset about your boyfriend and he's outside, you've seen this in the movies, right? And the boyfriend's outside and you're throwing his clothes out or something like that. That's defenestration. Okay. The only place I've actually heard the word defenestration used, and it means exactly that, things going out the window, is actually in reference to cats. Okay. Cats defenestrate themselves, which means they jump out of windows. A study was done in New York City, just looking at stats from vets, and they found that there's this odd little thing about cats and defenestration. They looked at the survival rates of cats that are defenestrated in New York. And of course, in New York, some cats are living, in high-rise apartments or something like that. And what they found is cats that defenestrate below a certain level, say the 7th floor or something like that, are likely to survive. Okay? And then cats that defenestrate above a certain level, which I think was like the 15th floor or something like that, are likely to survive also. It's just in the 7th to 15th floor range that cat mortality rates were highest.
Jumping out of 15-story windows?
Yes.
But like not out of 30 story.
Right. And so the science behind this is about what's called terminal velocity, which is when you're falling, air pressure against your body, the drag that's coming down, stops your acceleration at a certain point, because the force of acceleration and the force of air pushing against your body balances out. That's called terminal velocity.
So they just set up cameras outside to watch a cat fall out of a window? And
No, actually, they just went to vet offices and got data on cats that were treated because of defenestration. But what it seems to be is at a certain height, when cats defenestrate, their terminal velocity helps them stop falling, accelerating as they fall, and they can right themselves and land more successfully. So, go figure. Has nothing to do with anatomy and physiology. It's just what the word fenestration means. And it's an interesting story. I like my interesting stories. And now hopefully you won't forget that fenestration means window. Now the thing about fenestrated capillaries, which is different from the continuous ones, is that they have all these little holes in them, these fenestrations. And so the things that have to be actively transported across the endothelium and continuous capillaries can instead just diffuse through those little holes. I don't have any actual numbers. It would seem, however, that fenestrated capillaries are probably the most common, because in most tissues, we want some pretty good exchange from the blood to the surrounding tissues. One thing that's similar between continuous and fenestrated capillaries is the basement membrane, the associated connective tissue surrounding the outside of the endothelium, is one continuous sheet. So whether it's something that's actively transported across the cell or something that diffuses through one of the fenestrations, it still has to get through what's essentially a collagen mesh to diffuse out into the surrounding tissue. So there's a little bit of filtration membrane in either situation. And I mentioned that because the third type here, the sinusoidal, as they've drawn them especially, there are these big gaps in the basement membrane. It's incomplete, as are the intracellular clefts, what are gaps here. So there's big gaps between the individual cells as well as gaps within the basement membrane. And these are very leaky capillaries. Now, this is going to be found in organs where blood really needs to just flow directly into the tissue of the organ. We see them in the liver and in the spleen primarily. We don't see them in the kidney, which might sound kind of surprising. The kidney actually has fenestrated capillaries because while we do want to filter the blood going through the kidneys, that's its main function, there is some regulation over what gets filtered through. We don't want blood cells to leave this bloodstream and go into the kidney. So we have fenestrated ones. But in the spleen and liver, we do want the ability for blood cells to move through the blood vessel walls. In those two organs especially, red blood cells are cleared away. So macrophages in the liver and the spleen are very important for clearing red blood cells going through the liver and the spleen have to be cleared out, and so they have to leave the circulation and get in the tissue. The blood vessels in red bone marrow are probably sinusoidal also. I say probably because I actually haven't looked it up, but it would make sense because the spleen and the liver and red bone marrow all kind of do similar things. So they should all have that kind of blood vessel there. But again, this is not the same idea as I was just talking about with the arteries. These are 3 different types of blood vessels. These are 3 variations on one type of blood vessel, the capillary. And if we look at this figure here, the capillary beds in any given situation might not be the same kind of capillaries. So in the digestive tract, the stomach and the intestines, for instance, we probably have fenestrated capillaries. But in the liver, we have sinusoidal capillaries. This just says upper body, but that's going to include the capillaries going through the brain. So we're definitely going to have continuous capillaries there. So where exactly we look in the body, we'll have different types of capillaries. Whereas if we look at the arterial flow, we're going to have elastic arteries, muscular arteries, and arterioles going into the capillaries. And speaking of arterioles going into the capillaries, this is a representation of what capillary beds kind of look like. Capillary beds are much more extensive than this picture suggests, and they're kind of pared down here just so we can see what's going on. But arterioles give rise to a blood vessel coming off, which is called a metarteriole, which is kind of halfway between an arteriole and a capillary. It has some smooth muscles, cells wrapped around it, but it's not as continuous as an arterial wall. And there can be some exchange of nutrients and wastes across the wall of a metarteriole, just like we'd see across a capillary, but not necessarily as much. The metarteriole extends through the capillary bed and eventually merges into the venous side. And at this point, we don't call it the metarteriole anymore. This is the thoroughfare channel. The way this is drawn, where the capillaries are coming off of the metarteriole, there are little smooth muscle sphincters around that called precapillary sphincters. When they contract, they keep the blood from going into the capillaries, and the blood has to go through the metarteriole and the thoroughfare channel. And so here under metarteriole, it says serves as a vascular shunt when precapillary sphincters are closed, which is to say that if we don't want the blood going into that capillary bed at a particular time under certain circumstances, it'll just shunt through from one side to the other. But if those precapillary sphincters are relaxed, then the blood will flow through the capillaries and there'll be perfusion of blood through all this tissue. We don't see the precapillary sphincters down on the venous end of the circulation because blood's not flowing out of the metarteriole into these capillaries, but rather the blood would be flowing from the capillaries into the metarteriole and thoroughfare channel at this point. So this doesn't need a precapillary sphincter because blood's not supposed to flow back into that. Okay. But we do see it here where blood's being regulated as to whether it flows into the capillaries in the bed here. Okay. Also in this picture at the bottom, they have what's called an anastomosis. It kind of cuts off here in the projector, but anastomosis is A-N-A-S-T-O-M-O-S-I-S. Let me just spell that word out. This is a direct shunt from arterial to venous circulation. There are 2 types of anastomoses, which is the plural. In that picture, there's an arteriovenous anastomosis, which means artery to vein. There's also an arterial anastomosis, which means artery to artery. which is not in this picture. Okay, so this is an arteriovenous anastomosis here, going from the arterial side to the venous side of circulation. If we want to completely bypass capillary bed somewhere, then AV anastomoses, arteriovenous anastomoses, will allow for that bypass. When you're cold and you don't want blood going out to your extremities, then AV anastomoses help to bypass that. I had a friend in graduate school who was an MD Ph.D. student, which means he had no life. And he was actually interested in going into plastic surgery. And so the research he did was in microcirculation. And the animal model he studied actually was the rabbit. And he was looking at blood flow through the rabbit's ears. What he would do would be to apply various drugs to see if he could stimulate the AV anastomoses to make blood flow bypass the ears, which for a plastic surgeon would be great if you're trying to limit blood loss at a surgery site, if you could manipulate the ability of blood to flow through these anastomoses and therefore avoid the circulation out into an extremity, like for reattaching a hand or something like that. It would be great. And I think he was really interested in reattaching blood vessels for severed hands and feet. That was his main interest. So he's working on that in that particular model to see what drugs could help influence the blood flow through these anastomoses versus the rest of circulation. Now, in this, I mentioned arterial anastomoses, and let me just say something about that real quick. This is when an artery basically branches off a blood vessel and it grows and reattaches to the artery later on. These are most common in coronary arteries, although they can show up in other places. But if a coronary artery is blocked, then blood flow is going to be compromised to cardiac muscle tissue in the heart. And that would result in a heart attack. In older cardiac tissue, arterial anastomoses are actually a way for the heart to survive occlusions of blood flow. And it seems actually that it's more likely to happen in older people. So a 60-year-old is more likely to grow arterial anastomoses around a blockage than a 40-year-old, which actually tells you a little bit of why heart attacks in younger people are more devastating than in older people. My father-in-law had to go in for open heart surgery. He had 3 bypasses put in. And when they did that, they found one of the places they had to do a bypass around, there was 100% occlusion of the coronary artery, which would suggest that he should have had a heart attack, but he never had a heart attack. And that's because probably an arterial anastomosis grew around it. He was in his 60s at the time. But a 40-year-old with high blood pressure and cholesterol problems or whatever, if they develop a blockage, their coronary arteries can't grow this type of anastomosis to bypass it. Okay. So there is some age dependence on the likelihood of this type of anastomosis occurring. Now, the pictures I've been going through here, I didn't quite get to the last one, which I will pick up with next time, this one here, which is to talk about the anatomy of veins, kind of goes in with what we were talking about. Don't have time to do it here, but we'll pick that up next time, finish off talking about the structure of blood vessels, and then we're going to talk about blood pressure for the rest of next time, and we'll finish stuff up. So have a nice day.